not only on this topic, Ozempic and all the other analogs out there, Wegovy, which is basically just Ozempic rebranded. It's actually the same drug. They've just given it a new name because now they're saying, hey, we can use this for weight loss, and so, it's a smart pharmaceutical company. I can't blame them. Like, they're in the business of making tons of money. So I totally get it. But we're going to talk about those as well as the others. There's actually a lot of them in this category, in the so-called GLP-1 agonists, or the incretin analogs. We'll get into what that means, but there's actually almost a dozen similar types of agents out there. And I've been familiar with them for, gosh, I think the first of its class were released at least 5 years ago, maybe more, but seeing people on them in my practice, both in hospitals, clinics, urgent cares, ERs, of course. And I think you'll find very interesting that when they first were used, it was indicated only for type 2 diabetics. There was never any kind of weight loss indication, nothing like that. In fact, the original and only approved indication by the FDA was for type 2 diabetes. And so what they found was that a lot of these folks were losing weight. And sadly, the way that they lose weight was not always amazing. In fact, many of them lost a bunch of weight, but also lost a bunch of muscle mass too, which is not awesome. And we'll talk about why that matters, why it's important. We'll get into it. We'll talk about sarcopenic obesity, as it's called. Not to get too technical, but hey, I like the words that describe what's going on. So we'll get into a little bit of that, but we'll talk about what I think matters most, which is to you and I, and to those that we care about. Should they consider these medications? Could they be beneficial? And they may be. And we'll talk about if you are, or a family member or somebody is on these types of medications, how to optimize your success, not only for weight loss, but also for optimizing metabolism and not losing a bunch of muscle mass. We absolutely do not want you to lose a bunch of muscle mass, which sadly has been seen in a lot of studies, including a sort of colleague, if you will, of mine, Peter Attia. Many of you know him. He wrote an amazing book called Outlived. If you don't have his book, go for it, grab it. I enjoyed reading it. It was a little bit thick. It was kind of like my first edition of my book, Preventable, that you guys never saw because I lost it. I lost 800 plus pages of manuscript, and now it's distilled down. And if you're watching me over on YouTube, you can see it. It's right here. It's not too big. It's actually 300 some odd pages. Preventable, 5 powerful practices to avoid disease and build unshakable health. And it is out there. And Peter Attia, one of the things he shared, a couple of months ago, was that in his experience, and he's been using this medication on occasion, sort of the Ozempic and their analogs, the GLP-1 agonists, in his practice for certain indications, especially for the FDA indication, which was help with diabetes management for type 2 diabetics and blood sugar or glycemic control. And what they found is that in his, dozens and dozens, I think he mentioned a couple hundred patients that they had used these medications with over the time. What was really surprising, what was really concerning, if you will, very concerning, was that people were not only losing weight, but they were losing a lot of muscle mass. In fact, in his sort of small N, study group, if you will, those patients that he was immediately familiar with, he had roughly about 50% of that weight being lost was muscle mass. That is crazy. So if you were, let's just put out the number, say you weighed 200 pounds and you lost, let's say, 20 pounds. So if you lost 10 pounds of fat and 10 pounds of protein, like this would be a severe problem. You would actually leave the outcome, or in other words, when you lost your 20 pounds, you'd be at 180, but you would have lost 10 pounds of lean muscle mass and 10 pounds of fat. So at the end of this sort of, we'll call it a study, if you will, but at the end of this example, you would actually be more fat than you were at the start when you were 200 pounds, because you would have lost percentage-wise more of your lean muscle mass than the percentage of lean body weight. Unless, of course, you were exactly 50% muscle mass and 50% fat, which is, I don't think really any of us are built that way, but it's a concern. So we're going to get into that. It's called sarcopenic obesity. We'll get into how to prevent that if you are on one of these medications. all the stuff we're going to get into. It's going to be a lot of fun. We're going to reveal data. First of all, I just wanted to start with what the heck are these medications? Like a little bit of the skinny on what are called the incretin, incretin, incretin analogs. And incretin is really more of a blanket term for any gut-derived hormone, if you will. Many of them belong to this glucagon superfamily, and they are released when we ingest food, right? We ingest food, we ingest glucose, fat, protein. These things are released. One of the which falls into this category, GLP-1A agonist. So that's glucose-like peptide. I apologize, glucagon. Glucagon-like peptide 1 analog. And so what it does is it stimulates that receptor, the GLP-1A receptor, and it actually encourages insulin release after a meal in response to rising blood sugar. And that's sort of what we want, right? We want our insulin to be released after a meal if the glucose is going up, because if the glucose goes up and up and up, and there's no insulin to get the glucose down in the bloodstream, we have basically what my daughter has, type 1 diabetes, where she does not make her own insulin. And so it is life-threatening. If you have a really high blood sugar, you can go into this condition called diabetic ketoacidosis. You can actually die from that. So you don't want to have a super high blood sugar. And so in the body, we have this glucagon like peptide 1A receptor, and it basically helps the liver to secrete or to release insulin into the bloodstream. So your blood sugar doesn't go crazy and you don't have a life-threatening event with a life-threatening hyperglycemia. Sadly, as we know, many of us, including up to 8 out of 10, roughly, maybe even 9 out of 10, 88% was the original figure of those that were not metabolically healthy and that had some degree of insulin resistance. That was even pre-COVID. I think the number now is 92-ish% of us have some degree of insulin resistance. This process doesn't work ideally. In other words, we are becoming what's called insulin resistant, meaning our body is not responding normally to the insulin that's released. And so when that happens, we just keep pumping out more and more and more. And one of the cool things that this class of medications does, or the GLP-1A agonists, is that they actually do improve insulin sensitivity and the insulin release after a meal in response to hyperglycemia. So they've been shown clinical trials, this is with type 2 diabetics, of course, to improve insulin sensitivity, to decrease hyperglycemia or decrease the blood sugar so that they can improve things like A1C, many of them weight loss, improve some cardiovascular parameters, and so on. And it has been actually super helpful for this population. It's been studied in a lot of type 2 diabetics. And there are, gosh, I have a list here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 of them available on the market today. Most of us have only ever heard of 1 or 2 of them because those are the ones getting all the press, right? The Ozempics and the analogs, which the actual name is the semaglutide. And the reason we don't really use the semaglutide is because it's not available yet as a generic, which is one of the reasons why it's really expensive. It's about $1,000 a month, roughly, for this medication. And that's only 4 doses of it, right? Because you're getting it once a week, generally speaking. And that same one, semaglutide, is branded as both Ozempic and also recently, I think it was 2021, rebranded, same exact medication, same manufacturer. They now call it Wegovy, because they're getting an indication to use it for weight loss. Not for anybody's weight loss. There's still some more specialized indications. You're supposed to have technically obesity, which is a BMI greater than 30, for example, or an elevated BMI over at least, I think it was 25, 27. I forget the exact number. I'm not looking at the data there, but it was that in addition to some obesity-related comorbidities like hyperglycemia, elevated cholesterol parameters, high blood pressure, these kinds of things. And so it's not recommended nor indicated for everyone. And of course, why would we do that, right? We're not going to recommend pharmaceuticals for everyone. There are certain indications like the type 2 diabetes that originally got its indication for, but now they've rebranded it, called it Wegovy, and it's the same exact thing. It's no different. The only difference is that they're allowed to use even a higher dose of it, which, I mean, go big or go home, right? But I not necessarily a fan because of the potential side effects. And besides, possibilities of life-threatening side effects like the medullary thyroid carcinoma or thyroid cancer, pancreatitis is another common, I shouldn't say common, not common, but another severe potential problem with this medication. So if you've ever had pancreatitis, if you've ever had thyroid issues, especially any thyroid cancer, you shouldn't, or if it runs in your family, wouldn't be taking this medication. Those are the severe side effects. Many people have the common ones. I have a family member, in fact, that's on one of these medications. And what I'm bummed about, and I'm not going to say who it is, but it's a close family member. So this is like a first degree relative, like a sibling or a parent, really close to me, is that they started the medication without telling me, because honestly, to his or her credit, they didn't really know much about it. They're kind of one of the peeps, which many of us are. We just trust our doctors blindly. And this family member does have type 2 diabetes, and the doctor said, here, take this, and didn't really think about it much. And I've seen some of these side effects, especially the common ones like nausea, vomiting, diarrhea, stomach upset, like zero appetite. Pretty much this person has been struggling a lot because literally no appetite. And sadly, the one thing, well, actually, there's two things that this person can or can have tolerate, let's just say. The only two things that seem good to this person are, I hate to even admit it, but it's basically one of those meals at Taco Bell. It's like the Nacho Bel Grande or something like that. And then, some kind of highly processed soda cracker. I forget which particular brand they like. But those are really the only two things that even sound reasonable to eat while on this medication. And it's crazy to think because, well, how can you get all the nutrients that you need out of a highly processed cracker of some kind and a Taco Bell meal? Like, probably not happening, right? I think most of you would agree that's not really possible. And so that is concerning me a lot. This person has lost weight, which he or she is really happy about, but the nutritional status is really, really concerning me. And so that's one of the concerns I have with this particular medication, is that folks don't have a lot of appetite, which, at face value sounds like a really cool thing because they're eating less calories. And if they're eating less calories, usually they're losing weight. But this method, at least when it is used and you have significant weight loss, which often happens fairly quickly in the studies where they've looked at this, between 10 and 30 pounds of weight loss in the first year, 10 being super common, 20 moderately common, 30 still relatively common. Like, people are losing a decent amount of weight on these medications. And that may be a good thing if you're not losing muscle mass and if you are getting the appropriate nutrients. And so the sad thing is the majority of folks, at least that I've seen in practice and out there in the world in the data, which is everybody else's combined experience, is that they are not getting the nutrition that they need. And I think that's a big miss. And most doctors don't really even think about that. Most doctors don't have on their team a dietitian that's skilled in this, nutritionist that's skilled in making sure we're getting adequate nutrition, especially protein. We're going to get into that in just a second. But those have been some of my sort of early on concerns with these medications, is that people are not getting sufficient nutrition and they're losing a bunch of weight, and too much of that weight that is lost is in muscle mass. Some people may not even know or have heard about that because they just see the number on the scale and they're like, oh, that's cool. There was actually, let me see if I can find it for you, a recent study that showed the numbers on this. It wasn't quite as extreme as what Peter Attia shared, where 50% of lost weight in his patient population seems to be muscle mass, and the other 50% fat, roughly, those are the numbers that he shares. The data that I looked at, let me see if I can find it here for you. Because that's my concern, is that these type of medications, both Ozempic and many others, whether it be Mounjaro or now the rebranded Wegovy, is that they can have serious issues with loss of muscle mass, also bone density, and what I would call the structural elements of your body, that keep you upright, that keep you moving and thriving, all the collagen and things. They say loss of muscle mass, reduced bone density. And it is quite common because the rapid weight loss that occurs from these GLP-1 medications causes significant loss in muscle mass. And I'm trying to find the exact study. Here we go. Clinical trial. Let me see where this was. 68 weeks. So this was over a year. And in this particular trial, where was it? The sarcopenia, which is loss of muscle mass, was readily apparent. And they did, in this particular trial, they did what was considered the gold standard for really looking at this, which is a DEXA scan. And unfortunately, the FDA doesn't do the DEXA scan as part of their looking at these medications, for example. And they're just looking at raw numbers. They're looking at weight loss, the numbers on the scale. They may be looking at BMI, and neither one of those really can measure adequately or appropriately the potential for protein or muscle wasting, or the sarcopenia, which is muscle loss. And so it's a big concern, because body composition is critical. It is literally one of the most important things when it comes to our metabolism, because as I've shared in previous podcasts, one of the things that keeps us metabolically alive and doing well and burning all the calories we want is our muscle. Our muscle is that secret sauce, that secret ingredient. It is the most important muscle with respect to metabolism, is muscle. And so if we are losing muscle by being on a weight loss medication, I'm going to say that's not really a good thing, especially if the percentages are similar to the amount of fat, or even 20% or 30%. That would still be, in my humble opinion, too much muscle loss. And like I said, these can potentially be mitigated by doing a few things, right? Like making sure you get enough protein. And my family member who's eaten, some kind of saltine crackers and, some Taco Bell meal, the Nacho Bel Grande, I think, was the one that was shared with me. That is not enough protein. It is simply not enough protein. And one of the key things that you can do on a day-to-day basis, whether or not you're taking any of these medications, is to make sure you are getting adequate protein. And for most people, that's going to be between 0.7 and 1 gram per ideal body weight. Just a number to throw out there for most of us that we could use as a starting point is 100 grams of protein. Most of us need at least 100 grams of protein, or 30-ish, a little bit more than 30, right? At every meal, if you're eating 3 meals a day, that is, to make sure you're getting sufficient to, not be losing your own muscle, because that's the sad thing about muscle, is that it will be sacrificed if you're not getting enough protein. Like my family member that's not eating enough protein and that's losing a bunch of weight and happy about, sadly, the protein loss is what's got me really concerned. So this is something that I'm trying to share and to not only educate, but try to see how I can help, because protein is critical. And for most of us, I think this person included, if we're not getting it in our 3 meals a day or 2 meals a day, if you're on intermittent fasting protocol and you're only doing 2 meals a day, that was one of the reasons I personally stopped sort of that traditional 2 meal a day approach, because I just couldn't get enough protein. My goal is 150 grams a day. My ideal body weight is 150 pounds. I want to do at least 1 per pound, 1 gram of protein per pound, because I'm not trying to lose any weight at all. And I want to even build a little muscle mass. So my sort of minimum that I set for myself is about 150 grams of protein a day. And if you can think about what that means, if you eat 2 meals, 75 grams per day, or I apologize, per meal, that's a lot of protein. That's a lot of protein, 75 grams in 1 meal. And I was just struggling to get it in. So one of the things that I did, and that I still do, even eating 3 meals a day, is I add a protein shake. And in my particular protein shake, I throw in 3 scoops, which is about 30 grams right there in the protein shake. And what I like about the one I use is it not only has high quality protein, and there's both a vegan option as well as a whey isolate option, but there's also some vitamins and nutrients. And this is kind of one of the things I was recommending to my family member. If they just can't get anything down because they're so nauseous, maybe they can try one of these protein shakes that I use, because it does have protein, which is what I really want to increase the ingestion of, because I don't want any more sarcopenia or muscle wasting or muscle loss to happen, because at the end of the day, it's going to be super counterproductive. Why? As I mentioned, most metabolically active tissue in your body is your muscle. And also, as your muscle mass goes down, basically all your other health problems go up. So as the example I shared with sort of the PETA Peter Attia type patient, if you're losing half muscle and half fat at the same time, you are actually, though you weigh less at the end of the day, the most likely thing is you will be more fat in the sense of body percentages. You will have a higher percentage of body fat when you're done than you will have when you started, even though you were, in the case I used, 20 pounds heavier. And that's not a good thing. Losing muscle mass is no bueno. No bueno. Definitivamente que no. It's just not something that you want to do, because not only does it affect your metabolism, but all of the parameters that we want to have ideal or optimal health revolve around having adequate muscle mass, just to do our circumlocution, to get around throughout the day, to do the things that we want to do, to be unencumbered, not just the simple stuff, to get up out of a chair on our own without assistance, get up and go, to be able to walk around, to be able to pick up our grandkids or whatever that looks like for you. We can't do it if we don't have adequate muscle. So one of my other colleagues who, I love how she shares this. She says, our problem today is not that we're over fat, it's we're under muscled. We just don't have enough muscle. And this is Dr. Gabrielle Lyon, who's awesome in what she does. She is what I would consider one of the leaders in protein and one of the leaders in encouraging us to not lose muscle, to not get sarcopenia. She has a whole basically clinic and work that she does, which is helping people to increase their muscle mass, which will, of course, increase their metabolism. She calls it, I believe, either protein-centric medicine or muscle-centric medicine, something like that. In fact, I'm hoping to get her on the show here because it would be, I think, helpful to hear it from her, who's really one of the leading experts. And we've been in chats, and it's just been hard to schedule today. So I'm hoping to get Dr. Gabrielle Lyon on a podcast to talk more about that sort of muscle-centric medicine, because it's one of the, I think, most effective things to not only keep us young, feeling great, but also for our metabolism. So I think I've made the point there, but here's the thing. Let me just share this data. So in this subset, and this is by Dr. Carl Nadolsky, and he's with the American Board of Obesity Medicine. In his own group, here's what he says. The total mass loss was about 14 kilograms, which is pretty cool. That's like over 30 pounds of the folks that he was studying that are on these GLP-1 agonists. About 8 kilograms or 60% was fat loss, and over 5 kilograms was muscle loss, which that's pretty high. I mean, it's, 40% of that was muscle loss. That's too high. He admits it was too high and it was concerning to him. And what he said is that the DEXA scan is important to add to your armamentarium, because it's a good way to look at not only fat percentages but muscle percentages. And it was concerning to him that in his group he was also seeing, just like Peter Attia mentioned, people losing too much muscle mass. And I'm concerned. I'm concerned for this family member of mine. I'm concerned for anyone who is on any of these medications, that they could potentially have issues with increased loss of muscle mass, which is going to make it way harder for them in the long term to be able to not only keep the weight off, but to be metabolically healthy. So there's also other studies that look at these medications, and the overwhelming majority of folks who have discontinued them within 1 to 2 years will regain most of that weight. And that has been substantiated by a couple different studies that I looked at. Let's see, this one, dietary trials higher on protein. Okay, this is one I wanted to share later. Maybe I'll just share that now. But one of the ways to mitigate this, what's called sarcopenia, right, losing muscle mass, is to be able to increase your protein in your diet. And if you have absolutely no appetite, like my family member, it's going to be a little bit hard. This is a nutritional review, 2016, and it says effects of dietary protein intake on body composition. Changes over weight loss in older adults, systematic review and meta-analysis. And basically what they found is that as you increased the protein, and they were looking at least 1 gram per kilo per day, and they were increasing that because in my opinion, that's not enough. But as they increased the protein in the diet, they had less sarcopenia and they had better body composition. So effects of dietary protein intake on body composition after weight loss. And so what this study and many others have shown is that if you make sure you're getting adequate protein, so if you're on one of these medications, most likely you're going to be eating less. That's basically how they all work. Couple of mechanisms. One, you have less appetite. You just don't eat as much. Two, they actually delay gastric emptying. So in other words, the food sits around in the stomach a little longer, which makes you less likely to want to eat right away because the food's just kind of smoldering around there in the stomach. And this is often why people get nauseous from it, because it slows that process, the transit, if you will, of food out of the stomach. And so you feel full longer, right? It just kind of sits there, smolders around. And so the signal to your brain is like, I still got food down there. I'm not really hungry. So it decreases your appetite. It makes you feel full or have that satiety longer. And at the end of the day, these both result in eating less calories. It's a form generally of caloric restriction, which is fine to lose weight because you got to have less calories than you're burning, right? It's sort of simple science. It's not exactly a one-to-one thing because there's other things that matter, like what you're doing besides just cutting your calories, right? The nutrition you're putting in. So protein is key. It's crucial. It's critical. You have to make sure you're getting enough. My simple rule is 0.7 to 1 gram per pound, not per kilo, per pound of ideal body weight. That's to maintain your protein so that you're not losing anything. So if you're on any of these medications, make sure you're getting 0.7 to 1 grams per pound of ideal body weight. A great place to start for most of us is 100 grams a day. Make sure you're getting 100 grams a day of protein, or about 30 grams with every meal. And if you just can't do it because none of the food sounds good to you, you're not craving it, whatever, message me and I can help with some protein recommendations. I just think this is so crucial. So number one, you got to prioritize your protein. Now more than ever, if you take these medications, your nutrition has got to be prioritized. The second thing is your activities. In other words, your resistance training, lifting weights or doing any kind of body weight. Like I'm trying to simulate an air squat here, but I got a broken ankle. So it's a little hard I'm just kind of lowering my shoulders and trying to simulate the air squat here. But doing body weight exercise is a simple, easy way to do this. Push-ups, pull-ups, air squats, lunges, burpees, planks, like whatever. Fit these in all throughout the day. Keep dumbbells, which I do at the base of my desk. And I just kind of pick them up. You can't help it. If you're seeing those things all day long, you're going to pick them up and do a set of 10 or 20, depending on the weight, whatever that is. You have to do some version of resistance training. So if these are the two takeaways that you go home with, I would be happy. Make sure you're getting adequate protein, at least 100 grams a day. Make sure you're doing some resistance training at least 3 days a week. At least, I would say do a little every day, right? As I'm doing my air squat here. Do something every day. Not the same thing. I mean, mix it up. Maybe pull-ups one day and air squats and burpees the next day and planks the next day. Like mix it up, or if you got a home gym, hit that at least 3 days a week. You've got to do something to keep your muscle mass up. This is critical, not just for those who are taking these medications, but for all of us. This is mission critical. Get adequate protein. Make sure you're doing resistance training, because I feel like these medications can definitely benefit people, and they've been shown to help people with type 2 diabetes, for example. But I just don't want you to have these adverse consequences. We haven't even talked about the Ozempic face, right? People have messaged me about what the heck. So basically, it's just because of the extreme speed, you're losing weight quickly. Some of that fat, in your face, as I'm kind of touching my face here, you can see on the YouTube video, it disproportionately, for whatever reason, you lose fat there as well, and maybe some muscle in there as well. And so that can result in sort of sagging of the skin and wrinkles and all that stuff if you lose weight too quickly. And I would say that's going to primarily happen if you just cut out all the calories, or a lot of them, like my family member did. I think she lost either 20 or 30 pounds, like within a couple of months. Like it was a pretty significant amount. And when you lose weight quickly, not only are at risk for losing the muscle mass, like I mentioned, but in your face, you might have a disproportionate loss there, or at least a more noticeable, let's just say more noticeable loss, causing this kind of Ozempic face, which is the sags, the wrinkles, all these kinds of things that many people will not be super happy about. So there's ways to mitigate that, which the number one way is exactly what I've just been harping on. Eat enough protein. Also, don't lose muscle. Like those are two really important things. Also, adding collagen to your diet, one of my other favorite supplements. Most of you know this that have been listening. It's the most dominant Protein, in other words, most of the protein in our entire body, the overwhelming majority is collagen. It's collagen. And if you're not taking any, or you're not having a bunch of bone broth, you're not getting enough. Because what increases collagen production is the stimulation of which occurs when we intake collagen. So when you eat it, especially if you have vitamin C with it, and most collagen preparations nowadays do have that because they get that, your body will be signaled. It's like, hey, we're seeing collagen here and it's coming in with vitamin C. We need to make something of this. And boom, it starts making more collagen. So there's the primary ways to avoid this kind of thing. Make sure you get enough protein. I've said that so many times. Make sure you get enough protein, or your family member, whoever may be taking this. Or if you're not taking it like me, make sure you still get enough protein. It's so important. And number two, make sure you're getting enough resistance training, body weight exercise. You got to do it. You got to do it. These are critical. It is mission critical. And I'm gonna leave it there because there's a few more questions. I don't want to make this too long. We can do an episode number 2. But the parting thoughts are that this medication can be helpful. And I'm not shining it. I'm a doctor, for crying out loud. That's how I trained. I know how to prescribe medications. But I think in a lot of cases, we don't pay enough attention to how to ideally or optimally use these things, which can be helpful. And like this has been shown to be increasingly helpful for type 2 diabetics, for example. But I think we can optimize the result, especially if we're making sure we're getting adequate nutrition. So if you know somebody that may be taking these that's not getting adequate nutrition, send them my way. I can help. I would love to help. You got to get adequate nutrition. This starts with prioritizing protein. And guess what? Protein does what Ozempic does. It makes you feel full. It has satiety benefits. You will eat less. You will eat less if you start your meal with protein. You got to do it. Add protein to your diet, move your body, do resistance training, do all the things. Follow me over there on social, Dr. Thomas Hemingway, Dr. Thomas Hemingway. And feel free to ask me whatever question you want. I answer all my own messages. I usually can get around to it. If you want more access to me, you got to join the 60-day coaching because you'll have lots more access, or join my Thrive community. I would love to see you there. So until next time, thrive. Don't just simply survive in life. And aloha. Until next time. Thanks for watching, and remember to like, subscribe, hit that notification bell so you never miss out. Aloha.